This is a chest radiograph of a young woman presenting with sudden onset of chest and shoulder pain. The frontal radiograph shows a crescentic lucency beneath the right hemodiaphragm, representing free intraperitoneal gas. Another lucency is seen above the right kidney, within the hepatorenal fossa. This appearance is referred to as the Doge's cap sign, as it resembles the pointed cap worn by the historical leaders of Venice. These findings are characteristic of pneumoperitoneum, in this case secondary to a perforated peptic ulcer. The main differential diagnosis for a curvilinear lucency beneath the right hemodiaphragm includes a subpulmonic pneumothorax and free intraperitoneal gas. The key to distinguishing between them is the patient's position. On an upright chest radiograph, gas in this location is almost always intraperitoneal, whereas on a supine radiograph, it could be either subpulmonic, pleural air, or free peritoneal air. If there is any diagnostic uncertainty, additional views can help. An upright or left lateral decubitus radiograph is particularly useful, as free intraperitoneal gas will rise and outline the inferior surface of the diaphragm, while pneumothorax air will collect apically or along the lateral chest wall. It is also important to be aware of mimics of free peritoneal gas, such as colonic interposition, Chilaidite sign, in which haustral markings are visible beneath the diaphragm, helping to differentiate it from true free gas. Several other radiographic signs of pneumoperitoneum can be seen on chest and abdominal radiographs. These include the continuous diaphragm sign, in which gas outlines the entire diaphragm across the midline, the Doge's cap sign, as seen here, generalized increased lucency over the liver, the Wriggler sign, where both sides of the bowel wall are outlined by gas, and the triangle sign, representing small pockets of gas trapped between loops of bowel within the mesentery. Pneumoperitoneum most commonly results from perforation of a hollow viscus, such as a perforated gastric or duodenal ulcer, but may also follow trauma, recent abdominal surgery, or percutaneous catheter procedures. Less commonly, air can track into the peritoneum from a pneumomediastinum. Management is directed toward confirming the presence of free intraperitoneal gas and identifying its source. When encountered in the reading room, it is essential to review the clinical history to determine whether the patient has had recent surgery or procedures, as postoperative free gas is common and usually resolves within 7 to 10 days. In a patient without recent surgery, pneumoperitoneum should be assumed to represent a visceral perforation until proven otherwise and is a surgical emergency. Increasingly, CT is used for confirmation and to locate the site of perforation, as it is far more sensitive than plain radiographs. In summary, these findings represent a pneumoperitoneum secondary to a perforated ulcer, demonstrated by a crescent of gas beneath the right hemidiaphragm and the Doge's cap sign, a classic, high-yield radiographic diagnosis that requires urgent surgical attention.